Well, good evening, everybody. Welcome to tonight's lecture. Vet Education is proud to present a free webinar on the Great Colloid Debate, a 2022 update. This webinar is being brought to you by an upcoming vet education online course for veterinary nurses and technicians called Fluid Therapy in Small Animal Practice. Starts on May the 30th, runs for 4 weeks. I'm going to tell you a little bit more about the course as we go through the session tonight. My name is Philip. I'm your speaker for tonight's session. And as you will see from the title of this lecture, The Great Colloid Debate, a 2022 update. Back in 2015, we gave a lecture on the Great Colloid Debate. And there's been quite a bit of literature that's been published on the use of colloids between then and now. And some of our recommendations have changed. So in order to keep up with what is best and safest for our patients, I thought we'd have this update on fluid therapy. So what's the plan for tonight? The plan is we're going to talk about the origins of the debate. A little bit of this will be a recap for some of you who are Vet Education webinar members who have seen that video on the Great Colloid Debate. But for those of you who have not, we're going to just have a talk about a bit of a wander down memory lane, looking at the history of why we actually are having this lecture at all and what's so good about colloids or what's so bad about colloids. And then we're going to have a look at what the research now says between the years of 2016 and 2022. And finally, we're going to finish off not just with research, but with practical recommendations that you and I can take into our veterinary practice tomorrow and start to use. So let's have a look at the origins of the debate. Okay, in 1998, human albumin infusion into critical patients was associated with 1 additional death for every 17 patients treated. This came out of a multi-center review into albumin transfusion. So this raised the question about large molecular weight fluids like albumin being administered to critically ill patients and whether or not these fluids were harmful or not. Now, I know there's a lot of variables to consider. Potentially, the patients who received albumin were more sick than those who did not receive albumin. And so that may have been a confounding factor in the conclusions from the study. However, certainly albumin infusion into critical patients was associated with 1 additional death for every 17 patients treated. Throughout the early 2000s, we used synthetic colloids fairly widely in a large number of patients with sepsis and septic shock, under the impression that in patients with systemic inflammation, so systemic inflammatory response syndrome, SIRS, sepsis and septic shock, we would have an increase in capillary permeability. And this is what we presumed was leading to albumin loss and fluid loss out of our blood vessels and into our interstitial spaces. Subsequently, in those patients with systemic inflammation and sepsis, blood volume shrunk and our patients went into shock. And it's very difficult to manage those patients when they're in shock just by using fluid therapy. So it was thought that the use of large molecular weight compounds like hydroxyethyl starch, which is many times larger than albumin in terms of molecular weight, would be so large that they wouldn't leak out of these capillary beds with increased capillary permeability, and subsequently that we would lead to that we would have a greater intravascular volume and that our patients with sepsis and systemic inflammation would have better blood volume, better tissue oxygen delivery, and subsequently an improvement in mortality. However, in 2011, it was found that key research proposing the benefits of synthetic colloids, as I've just described, was found to be fabricated. And that led subsequently to a large number of publications being removed from the scientific literature discussing the use of both synthetic and naturally occurring colloids in the management of patients with critical illness. In 2012, there were two large trials that I'm going to go into in a couple of seconds, CHEST and the 6S trial. They were released, and what they concluded from these two different trials, they found that hydroxyethyl starch administration was associated with a higher risk of acute kidney injury and mortality. And the press and media got hold of this, and there was a fairly significant amount of publicity in the media, saying that doctors were administering killer fluids to patients in hospital. And so subsequently, throughout the European Union, hydroxyethyl starch was removed from hospitals. And in 2013, on the basis of a review of the CHEST and 6S trials, the US Federal Drug Administration issued what's called a black box warning, or an official warning, stating some limitations on when they recommended the use of hydroxyethyl starch. So that's a bit of the history on the origin of this debate. But it's not quite as plain and simple as that, as a lot of things in medical science, in fact, science full stop, nothing is 100% certain until it's proven beyond doubt, right? So let's just have a look at things in a little bit more detail. Do colloids do any good? Why were we using them in the first place? Well, there are a large number of studies from the 1990s and 2000s that were not removed from the literature because they had non-fabricated results. Okay, so this is high quality literature that suggested that infusion of colloids to patients with critical illness caused an attenuation of the inflammatory response. Okay, so you could have a severe systemic illness, administer colloids, and inflammatory biomarkers were reduced. And so we got an attenuation of the inflammatory response. And there was also a mitigation of endothelial barrier dysfunction and subsequently a reduction in vascular permeability. So we're actually improving endothelial barrier function in patients with severe illness. There's also evidence from a large number of experimental and in human clinical studies that intestinal barrier function was improved as well. Further studies looking at hydroxyethyl starch demonstrated an improvement in microvascular circulation in patients with sepsis, along with more rapid hemodynamic stabilization and reversal of shock in patients that didn't have septic shock. And I've also already mentioned improved intestinal wound healing and anastomosis bursting strength in intestinal surgery. And several studies demonstrated that patients required less volume to treat shock if they were resuscitated with hydroxyethyl starch than if they were receiving just crystalloid fluid therapy. And I'm going to talk a little bit more about this last point later on, because this is actually quite important because evidence that we are receiving now suggests that fluid overload is a big problem in patients with severe or critical illness, in that we end up with a much greater accumulation of interstitial fluid, and that decreases oxygen delivery to tissues and subsequently leads to worse patient outcomes. So this is something that we're just going to tuck in the back of our minds, and we'll reapproach this and when it comes to our practical recommendations of what we need to do. So on the basis of what's on this slide, colloids seem pretty reasonable. Attenuated inflammatory response, better endothelial barrier function, reduced vascular permeability, preservation of intestinal barrier function, better intestinal wound healing, all those sorts of things, and less fluid required to treat shock. There's more than that, though. There's patients that were resuscitated with synthetic colloids in several studies demonstrated less days on a ventilator. They required less fluid for resuscitation during their entire hospital stay. They had, on general, shorter hospital stays, an earlier return to bowel function, particularly following intestinal surgery, and less requirement for the use of catecholamines like noradrenaline, for example, and dopamine and dobutamine in patients that were on hydroxyethyl starch versus those who were just resuscitated with isotonic crystalloids. So colloids do have some practical advantages, at least in reference to the published literature prior to 2015. Why the controversy then? If colloids are pretty reasonable, why the controversy? Well, isn't this increased risk of the death pretty plain and simple? Like, surely if you're giving a fluid that's more likely to lead to your patient dying, surely that's pretty plain. Should we just ignore the benefits of the synthetic colloids and just do without them? And that was the reason why there was so much controversy, because there's so many good things about colloids and a few bad things about colloids as well. So here we go. This is a large reason for the controversy, in that the 6S trial and the CHEST trial actually used some interesting criteria for inclusion. And I'm just going to run through these briefly. In the 6S trial, all the patients were already in sepsis. So any conclusions that are made from the 6S trial really only apply to patients who are in sepsis. Okay, the endpoints for resuscitation were not standardized. So some patients got more hydroxyethyl starch than others, and many were poorly responsive to fluid therapy to begin with, but they continued to receive large amounts of either crystalloids or hydroxyethyl starch, even when they were poorly responsive to fluid therapy. And this can lead to an increase in fluid accumulation in the interstitial spaces and is known to be associated with higher mortality rate. So this is another thing that we need to be factoring into our interpretation of the conclusions from the 6S trial. Interestingly, many patients who actually were enrolled in the 6S trial had received hydroxyethyl starch prior to inclusion in the study. Even up to a litre might have been given to patients who were subsequently put into the crystalloid treatment only group before randomization. Okay. So this means that a patient who ended up in the crystalloid group may have had up to a litre of hydroxyethyl starch before they were in the crystalloid group, and subsequently had improved survival or less complications than those that were in the hydroxyethyl starch group. The fluid used as well was interesting, because there are a number of different types of hydroxyethyl starches, and the one that was used was a reasonably highly substituted one. This is the substitution number here, 0.42. So hydroxyethyl starch 130. 130 is the number of daltons of the average molecular weight of the fluid, so 130 kilodaltons, and the substitution rate on those molecules of hydroxyethyl starch was 0.42. So it's much more highly substituted fluid than the most common one that we use in veterinary medicine, which is Voluven, which is 130 0.4 substitution. So the substitution rate is a little lower, and it was thought that maybe that might have some impact on the results that we might see in dogs and cats. Let's switch over to the other big study that we're talking about, which is the CHEST study. There was also a wide cross-section of patients included. Many patients were resuscitated with colloids before randomization. In fact, 60% of the crystalloid group received colloid resuscitation prior to randomization. There was also a pretty wide variation of inclusion of patients into the study. There was a standard deviation of 7 days for study inclusion, which means that if we look at a bell-shaped curve, that the mean period of illness, for example, before a patient was included, must be somewhere around sort of 16 to 18 days or thereabouts for the standard deviation to be 7 days. This means that resuscitation from for a lot of these patients, okay, was well beyond 7 days, and some of them would have been ill for 14 days or 15 days before they got included in the study, and we can't really term resuscitation in those patients acute resuscitation, which is what the authors mentioned in their paper. So are there any other studies out there that can help, I guess, broaden the scope of what we're looking at? Well, yes, there are. There are some acronyms. I love these acronyms. Crystal and Christmas trials are two others that were produced in the between 2010 and 2014. Crystal had a wide range of colloids and crystalloids used to manage trauma, sepsis, and hypovolemia of any cause. So this could be hypovolemia secondary to diarrhea or other fluid loss, renal losses, sepsis patients, as well as trauma patients. So this is a wide cross-section of patients. Remember, the 6S and the CHEST trials were really focused on patients with sepsis and septic shock. Crystal had patients with sepsis, but also just hypovolemia from a number of causes and trauma. And they found no difference in mortality at 28 days. There was a slight increase in mortality in the crystalloid group at 90 days. There was also evidence of reduced life support requirements and vasopressor requirements with hydroxyethyl starch, which reflected some results from trials conducted between 2000 and 2010. The Christmas trial used a 6% hydroxyethyl starch, 130 0.4. That's the same that you get in Voluven, which is the most common one that we use in veterinary medicine. And they compared resuscitation with hydroxyethyl starch with 0.9% sodium chloride in patients only with sepsis. They found that there was less fluid required to resuscitate the patients with hydroxyethyl starch. There were no differences in renal function or dysfunction, but there was a trend towards, although not statistically significant, towards increasing renal replacement requirement in hydroxyethyl starch groups. So certainly there's a possibility in this trial that, again, patients with sepsis may be a little bit more at risk for developing kidney dysfunction. So the evidence up to 2015, which is when I last spoke on this topic, was that in sepsis, there was definitely an increased risk of acute kidney injury and a possible increased risk of death. This was backed up by a retrospective study in veterinary medicine looking at dogs and cats in response to patients who had had hydroxyethyl starch. And they found in those studies that mortality rates were a little higher in patients that had had hydroxyethyl starch. Being a retrospective study, it's really difficult to remove bias from these studies completely, if at all, in some particular data that you might be looking at. And in a retrospective study looking at patients in which we have been used to giving synthetic colloids to the sicker patients because we believe that our blood volume is going to increase when we give them, we're going to give more synthetic colloids to more critically ill patients. The more critically ill patients are more likely to die. So giving your patient hydroxyethyl starch and the patient dying are a part of the overall constellation of the fact that you have a really critical illness and therefore your patient's more likely to die. You've got a more critical illness, your patient's more likely to get hydroxyethyl starch. It doesn't necessarily prove a causative link between the hydroxyethyl starch and the death of that patient. So that's where we were in 2015. In acute diseases associated with anesthesia or acute vomiting and diarrhea, or acute gastric dilatation volvular syndrome, where the patient presents to you within 1 to 2 hours of being injured, maybe hit by a car, or developing a GDV, or developing acute symptoms of parvovirus, colloids may be associated with less fluid requirement for resuscitation, less requirement for vasopressors later on, less ventilation days, and less post-surgical complications, especially those that have intestinal surgery, where much of the research supports less post-surgical complications. So colloids certainly did have some benefit, or at least we thought that they did have some benefit in these particular patients. So back in 2015, we were saying it's probably still okay to use synthetic colloids in patients that are not septic, they're not in septic shock, and patients that have got acute illness, or healthy patients undergoing anesthesia, and you just want to give them a fluid bolus to try to help assist maintenance of blood pressure and so on. Just as a side note there, I just want to talk about crystalloids, because not all crystalloids are created equal. 0.9% sodium chloride we know is pretty high in chloride, and that does increase. Sodium chloride in numerous trials in people have shown to be associated with an increased likelihood of that patient developing acute kidney injury when compared to polyionic isotonic crystalloids like lactated Ringer solution. There's an increased risk incidence of metabolic acidosis. There is greater hemodynamic instability, and increased requirement for blood transfusions, an increased rate of post-operative infections, and they may be pro-inflammatory as well. So that's where we were in 2015. We are now going to embark on what we now know from research that's been published between 2016 and 2022. I just want to remind you that this lecture has been brought to you by Fluid Therapy in Small Animal Practice. It's a 4-week race-approved online course for veterinary nurses and technicians. We have had vets do this course before and they absolutely love it. So if you're a veterinarian and you're thinking, maybe I want to learn some more about fluids or refresh my memory, then feel free to get in touch with us or just enroll for the course, and I'll make sure that you are looked after with additional resources and journal articles and other things that you may wish to sink your teeth into. Let's get back to updates in the literature. In critically ill patients, so these are the patients who are in the intensive care ward. They have received massive trauma. They are perhaps post-surgical patients or pre-surgical, post-surgical patients who have significant disease, critically ill patients. There was a review looking at the choice of fluid therapy in the initial management of sepsis, severe sepsis, and septic shock. The conclusions in this study is a review, and hydroxyethyl starches appear to increase mortality and kidney injury in the critically ill and are no longer indicated or recommended in those patients. In the trauma population, there was a notable shift, in the reviews from colloids to plasma-based resuscitation when crystalloids weren't offering significant resuscitative value, with decreased use of crystalloids and colloids in the treatment of hemorrhagic shock, and that led to a decreased inflammatory and edema-mediated complications. So using plasma-based resuscitation, so albumin and fresh frozen plasma, to manage hemorrhagic shock led to a decreased inflammatory and edema-mediated complications. And this goes hand in hand with, the traumatic coagulopathy that we sometimes see in patients that are resuscitated with significant volumes of isotonic crystalloids. And I gave a lecture earlier this year on trauma-associated coagulopathy and the role of being judicious with fluid therapy when we're treating patients with significant trauma. This review really asks for more information. Studies are needed to determine if the benefits with plasma-based resuscitation also occur with a similar resuscitation strategy in the setting of sepsis. So there weren't really any firm conclusions. A couple of observations. One is that in the human medical field, that plasma-based resuscitation is being used a lot more for trauma patients, and it's associated with reduced complications, and that hydroxyethyl starch use was reduced. And we really need to find out if giving plasma to our patients with sepsis and critical illness is associated with similar survival benefits in our septic patients. The next review here looked at crystalloids versus colloids for fluid resuscitation in the intensive care unit. This was a systematic review, so they reviewed all of the literature and a meta-analysis of that literature. They found that mean arterial blood pressure was lower when patients were resuscitated with balanced crystalloids versus colloids. So you got better improvements in mean arterial blood pressure if you resuscitated with colloids. There were higher volumes of crystalloids that were required versus resuscitating patients with colloids. However, there was a higher mortality with hydroxyethyl starch when compared to crystalloids. So despite using higher volumes and not getting blood pressure as good, mortality rate was lower when you gave crystalloids as opposed to colloids. Now, this last part of the sentence here is really interesting. Gelatins, albumin, and dextrans, were associated with lower mortality than hydroxyethyl starch as a fluid. So this tells us in this particular study, and it looked at a lot of the studies, including the CHEST and Success trials and the Christmas trials that we looked at earlier. It looked at all of that information associated with patients in the intensive care unit, and found that still there's higher mortality with hydroxyethyl starch compared to crystalloids, albumin, dextrans, or gelatins. I'm going to talk about gelatins later on, so hold that thought. There was another review looking at intravenous fluid therapy in critically ill adults. Crystalloid fluids were recommended to be used as the first-line therapy in most patients. Buffered salt solutions seem to offer benefits over normal saline, and this is so lactated ringer solution is better than 0.9% sodium chloride. Albumin administration might be beneficial in patients with sepsis, cirrhosis, or infections, but we just need to make sure that albumin's in an isotonic solution when we're giving it in patients that have acute traumatic brain injury, because we don't want to give a hypotonic fluid to a patient with a traumatic brain injury, because that generally leads to a worsening of cerebral edema. So just albumin's got potential advantage in patients with sepsis, liver cirrhosis, and infections. Synthetic colloids, notably hydroxyethyl starch, as well as the gelatins they recommended, should not be used owing to their unacceptable safety profiles and lack of proven benefits over crystalloids. So whereas the last study said hydroxyethyl starch was worse than gelatins, this particular study, this review here, which was conducted in 2018, found that the use of gelatins was associated with an unacceptable increase in risk to the patient due to its poor safety profile. And as I mentioned, I'm going to look at a study that looked at all of the uses of gelatins in human beings and determined some problems with them. So they're a fluid that we would generally steer away from now. So the other thing they noted, we mentioned earlier already tonight, was that strategies that restrict fluid administration might reduce morbidity and mortality. So those patients that had a relatively conservative fluid resuscitation regime over their entire hospital stay tended to have lower morbidity and lower mortality. I'm going to talk about that in a few slides' time as well. And finally, I think in this section, we're going to look at the role of albumin, starches, and gelatins versus crystalloids in volume resuscitation in critically ill patients here. This was from a paper from 2016. Their recommendations from this review was that fluid administration be tailored to the patient characteristics rather than a one-size-fits-all. Synthetic colloids should be avoided when possible, especially in patients at risk for kidney injury. In critically ill patients with suspected increased capillary permeability, colloids don't appear to be superior to crystalloids in expanding plasma volume. And this is really a really important observation, and that what we now know is that when patients develop systemic inflammation and sepsis, the capillary permeability increases a lot, and our large molecular weight starches will be lost from the intravascular space and will be present in the interstitial space, where they can stimulate inflammation and can cause some organ dysfunction, particularly in the kidneys. Albumin, notably, does appear to be less harmful than synthetic colloids, although its beneficial effects need to be investigated further. And the endothelial glycocalyx, which I'll also mention in a few slides' time as well, is a key structure in finely regulating intravascular fluid distribution. So what I'm doing right at the moment, for those of you who have looking at this going, there's a lot of papers that I'm throwing at you here. What's this all going to mean for me and my patient? Well, if you bear with me for a few more slides, I've got a few more studies I'm going to talk about, and then we're going to just talk a little bit about glycocalyx, a little bit about fluid balance in our patients, and then we're going to take all of these studies and summarize the findings into practically applicable conclusions that you and I can use in our practice. So that's where we stand with critical care patients. Pretty much synthetic colloids don't appear to have much advantage at all. Maybe plasma has a little bit of an advantage. 0.9% sodium chloride we're probably going to avoid because of increased risk of kidney injury and increased risk of acidosis and hemorrhage and so on. And we're probably going to avoid gelatins due to some problems with their safety profile. So that's where we are with critical illness. What about trauma patients? Well, there's a synthetic colloid resuscitation in severely injured patients. This was an analysis of a nationwide trauma registry here done in 2018. They said any synthetic colloid use was associated with an increased risk of multiple organ failure. This is in a trauma patient, a patient we used to think maybe might have been in a slightly safer group to give synthetic colloids to because we thought they had intact capillary membranes and glycocalyx. Okay, so in any synthetic colloid use, no matter whether it was dextrans or gelatins or hydroxyethyl starch, was associated with an increased risk of multiple organ failure. Synthetic colloid use did not affect hospital mortality, but this analysis suggested that synthetic colloid resuscitation provides no beneficial effects and might even be harmful in patients with severe trauma. So bold statements from a very, very soundly conducted review. Let's have a look at this review here. There's another review here. This one was conducted in, 2017, looking at strategies for intravenous resuscitation in trauma patients. It was important to identify risk factors and priorities in trauma patients, for example, traumatic brain injury, penetrating injury, and blood loss, and so on. Consider early administration of blood products, which is something that, in order to avoid acute traumatic coagulopathy, is starting to be advocated more. In the absence of blood products, just to use lactated ringer solution or plasma-lyte for resuscitation. Provide just enough fluid that is required to maintain perfusion. Because any excess fluid administration has negative consequences such as dilution of coagulation factors, tissue edema, hyperchloremic metabolic acidosis, and subsequent organ dysfunction as well. Okay, so this was an excellent review. Is very, very well conducted. They're looking just at trauma patients, and the conclusions seem reasonably sound. So, identify your risk factors, early administration of blood products. So this is not only albumin, but this is or fresh frozen plasma, but also red cells if your patient develops decompensation due to acute development of anemia. If you don't have blood products, just use lactated ringer solution or plasma-lyte, so a polyionic buffered balanced solution, just enough to get your patient to maintain perfusion, then back off your fluids so that you don't get that excess fluid accumulation. So this means once you treat a patient for shock, you back off on your fluid administration rates to maintenance rates, maybe somewhere between maintenance and, if you must, up to maybe maintenance and a half, but we're probably not going to recommend twice maintenance fluids for our patient that is acute trauma patients after acute resuscitation, because we already have so much fluid in our patients after resuscitating them for shock. What about non-trauma patients? This was a comparison in a review of colloids and crystalloid use using goal-directed fluid therapy protocol in non-cardiac surgery. This was a meta-analysis of randomized controlled trials. Mortality, kidney dysfunction, hospital stay, complication, and bleeding were similar in both crystalloid and colloid groups, so really not much difference. Colloids and goal-directed fluid therapy didn't appear to offer any benefit over crystalloid therapy to patients undergoing major non-cardiac surgical procedures. So if they don't offer a benefit, one really has to ask, why are we giving them in the first place? So that was the results of that trial. Fluid management in acute kidney injury. Fluid recommended, hydroxyethyl starch is not recommended in acute kidney injury. Gelatins also shouldn't be used in management of acute kidney injury. Albumin appears reasonably safe, but we're not really sure if there's any benefit at all. So again, may not be something that's needed unless there's a patient who is bleeding or who has a severe coagulopathy and is at risk of internal hemorrhage. And 0.9% sodium chloride is associated with higher risk of acute kidney injury. So stay away from everything. Just use isotonic crystalloids unless your patient is bleeding in a patient with acute kidney injury. What about those patients in surgery? Well, there's a comparison of hydroxyethyl starch and colloids with crystalloids for surgical patients, and there was insufficient data to identify any difference in outcomes associated with crystalloid and hydroxyethyl starch in scheduled or elective non-cardiac surgery. This included intestinal surgery. So despite the benefits described in research and earlier clinical studies in people with intestinal surgery, there didn't seem to be a difference in outcomes whether or not you use synthetic colloids or not. Another review here looked at the effect of perioperative crystalloid or colloid fluid therapy on hemorrhage, coagulation, competence, and outcome. And they demonstrated increased blood loss being found in non-cardiovascular surgery among patients receiving hydroxyethyl starch compared with colloids, followed by a marked reduction in the thromboelastography clot strength. Okay, so we're going to, the clots that we have are not as strong and not as long-lived, and there was an increased risk of blood loss in that non-cardiovascular surgery in patients receiving hydroxyethyl starch. So again, probably not much value in giving hydroxyethyl starch. I mentioned gelatins, and we've talked a little bit about saline. Just want to summarize the findings here. There was a lovely article written in 2016 that looked at a systematic review and meta-analysis of gelatin-containing plasma expanders versus crystalloids and albumin. They found gelatins were associated, this is gelafusine, and those types of fluids are associated with increased risk of kidney injury, increased risk of mortality, increased transfusion requirements, and increased risk of anaphylaxis. They found in biopsy samples and postmortem studies that between 17 and 31% of the gelatin that was infused into a patient was found in extravascular fluid, so the interstitial fluid spaces. So this means that when we give gelatin to our patients, a significant amount of this fluid ends up in the interstitial spaces. The general recommendation is that we just should avoid them until there's any clear benefit. It doesn't appear that there's much benefit, and there certainly is an increased risk with using them. There was a veterinary study looking at crystalloid and colloid compositions and their impact on the patients. And the comment here is in the conclusions, there were studies focusing on immunological, coagulation, and kidney effects of hydroxyethyl starch products are not all in agreement, as we've just talked about for the last 40 minutes or so, and there may be species differences, but we really don't have enough evidence in the veterinary field for us to make strong conclusions. What we do have available to us, rather, is a significant amount of literature in the human field on the safety and potential benefit of these compounds. We do also have quite significant amounts of experimental evidence. It's worth noting that experimental evidence is useful, but it is not real life clinical evidence. They're useful insofar as the possibility that you could replicate the conditions of that experimental study when you are conducting surgery on your patients or managing your patients. So there are certainly imperfections in the way that and how far we can interpret a lot of these studies. This was also another review here. This is looking at balanced crystalloids versus saline in sepsis. Okay, this is a secondary analysis of the SMART clinical trial, crystalloid and colloid compositions and their impact. So what this here, this systematic review looked at is that amongst patients with sepsis in a large randomized trial, the use of balanced crystalloids was associated with lower 30-day in-hospital mortality compared with the use of saline. Okay, so we're going to use balanced crystalloids, lactated Ringer solution, plasma light over something like 0.9% sodium chloride. So that is the evidence of what we have regarding these fluids now when we come to managing our patients with intravenous fluids. Let's have a look at practical recommendations. How much fluid should we give our patients? Well, when we're thinking about giving patients fluid, there's really three phases that are described in both the human and veterinary literature, and they're based on acute kidney injury fluid therapy patients. And the reason why they're based on these patients is that patients with acute kidney injury suffer worse clinical outcome if they have excessive fluid accumulation. So the three phases that are described are acute resuscitation. This is where we're treating patients for shock. We're giving them transfusions to make sure they've got adequate hemoglobin concentrations. We're correcting coagulopathies if patients require treatment for that. We're normalizing electrolyte disturbances and so on. So that's acute resuscitation. Phase 2 is where we maintain intravascular volume homeostasis. So basically we've an acute resuscitation, we're making up for patients' deficits, okay? We're making up for patients' intravascular volume deficits. We're making up for hydration deficits. We're making up for clotting factor and red cell deficits. In the bargain there, we're probably going to correct a lot of acid-base disturbances as well without even necessarily needing to directly address those that are caused by hypoperfusion. But that's our acute resuscitation. The next phase is really maintenance. And this is why once we've treated our patient for shock and all of those things, why we can turn our fluid rates down to maintenance, because all else being equal, we need to maintain intravascular volume homeostasis. If our patient develops vomiting or diarrhea or has massive wounds and they're exudating a lot of fluid, they've got a pyothorax or something like that, yes, we need to maintain that patient's ins and outs properly. So we need to replace the fluid the patient is losing in order to maintain intravascular volume homeostasis. And the phase 3 is convalescence. Now I've got a graph here that puts this in perspective. Now some of you might be thinking, Phil, if I've got a patient who's been attacked by a dog and it's in shock when it presents to me, it's got wounds everywhere. I know it's going to ooze lots of fluid out of those wounds. Surely I treat shock, and then because the patient's going to ooze lots of fluid out of the wounds, I need to give it more than maintenance fluid. Or you might be thinking, I have a patient with parvovirus enteritis. It is in shock. It's dehydrated. So I'm going to treat shock, rehydrate my patient. If I turn that fluid rate down to maintenance, my patient's still going to have vomiting and diarrhea, and I need to have my patient on higher than maintenance rates of IV fluids. Have a look at these graphs, okay? And this will add some clarity. Phase 1 of fluid therapy is what we are doing when we treat patients with fluids for shock. The actual fluid administration rate that I'm giving my patient in phase 1 is all the way up here. The patient fluid balance, however, it's all I'm doing is restoring what its fluid balance should be, which is around this level here. Okay, so I give my patient an excess volume of fluids of this amount here. And we know this because if I was to give, say, 1 liter of lactated ringer solution to, let's say, a 12 or 15 kilo dog, I know that after 30 to 60 minutes, that 750 mils of that fluid is going to be sitting outside the blood vessels. It's going to be sitting in the interstitial spaces. So I've given my patient much more fluid than its blood vessels are capable of holding for a start. And now I have all of this excess interstitial fluid. In phase 2 of fluid therapy, what we have here is a patient requirement that's reasonably low. We give our patients less fluid than we would when we just basically give them maintenance fluid. The patient fluid balance, though, is still all the way up here because they still have all of this fluid from phase 1 that's left over. Okay, so I don't need necessarily to give my patient excess amounts of intravenous fluid once I've restored intravascular volume deficits and when my patient's rehydrated and so on. I can turn my fluid rates down to maintenance rates because for a period of time, and it might be 12 or 24 hours, depending on the patient, my patient has excess fluid to requirements because all of that crystalloid I've given them, 3/4 of it is sitting in the interstitial spaces. Phase 3 is where we have basically everything equilibrating out again, where we give our patients the same amount of fluid that they're excreting. So with this in mind, if I have my patient on intravenous fluids and I treat them for shock, if I then put my patient who's not potentially bleeding or maybe doesn't have vomiting and diarrhea, maybe they're a pancreatitis patient who just has some nausea, some abdominal pain, maybe the odd vomit with not too much in the way of fluid loss at all, and I continue to give them twice maintenance fluid on top of the fluid that I've already given them to treat them for shock if they presented with hypovolemic shock, And then I can end up with a patient who has much more fluid than it needs. And we know that excess fluid is associated with high mortality. So the take-home message is, if you have a patient in shock, treat it really aggressively with your intravenous fluids, treat it nice and early, and then back off on your fluid rates. So turn your fluid rates down to maintenance rates of IV fluids until you know what your patient needs. Now, I'm going to come back to the parvovirus dog that I mentioned before, that one that you might treat for shock. It looks heaps better. You put it in a cage, you give it its antiemetics and antibiotics and everything else that you might want to give your parvovirus patient. And then half an hour later, the dog has horrendous hemorrhagic diarrhea. It's vomited 5 or 6 times in the cage, and now it's showing clinical signs of shock again. Wouldn't that patient have been better if I put it on twice maintenance fluids? Wouldn't I have been ahead of the game a little bit, like given a little bit more fluid in reserve, so that when that patient vomited and had diarrhea, that it had some extra fluid to call on? The short answer is no, you're not better off putting that patient on twice maintenance fluid rates, because if you do that, all you'll do is increase the amount of interstitial fluid accumulation. Interstitial fluid accumulation does not necessarily translate to a rapid intravascular volume replacement when your patient has vomiting and diarrhea. So it's very hard to get ahead of fluid loss in your patients in a meaningful way. So what would I do when my patient has hemorrhagic vomiting and diarrhea? I would give my patient another 1 or 2 boluses of shock rates of IV fluid therapy, then turn them back down to maintenance. Yes, your monitoring needs to be really spot on. You need to be weighing your patient frequently to make sure that your patient's not becoming dehydrated and that you are giving enough intravenous fluids to manage your patient's disease. This doesn't only apply to parvo patients, but it's a nice example. It could also apply to pancreatitis patients, patients with wounds and those kinds of things as well. But that's how I would manage those patients. What are the endpoints as well that we're looking at? Because this is something else we need to factor in with fluid therapy. Well, lactate clearance, the amount of lactate that disappears from circulation over a period of time, that is better than using things like urine output and blood pressure to measure perfusion. Poor response to intravenous fluids, so lactate not changing at all, or your blood pressure not improving, urine output not improving either. Poor response to intravenous fluids suggests that you might need to use vasopressors like noradrenaline and inotropes like dobutamine instead of just continuing to give your patient lots and lots of fluids. So my approach in a septic patient or a patient with severe inflammation, dog attack victim, severe road traffic trauma, GDV patient that's not going well, patient with a ruptured spleen that's in sepsis by the time I get to it, or severe inflammation, is if my patient does not respond to between 1 and 3 boluses of intravenous fluid at shock rates. So that for a dog, that's 10 mils per kilo of lactated ringer solution in 10 minutes. For a cat, it's 7 mils per kilo over 10 minutes. If I give my patient 2 boluses of lactated ringer solution at shock rates and the patient's heart rate, blood pressure, urine output, or his blood lactate doesn't change at all, then I'm going to be reaching for, firstly, dobutamine to improve cardiac output in my patient, and secondly, noradrenaline to increase the increased vascular tone so that I get an improvement in blood pressure. If our patient doesn't respond to fluid therapy and you've given it hydroxyethyl starch already, then don't give any more. Just use crystalloids and vasopressors and inotropes to improve perfusion. So here's a little bit more information just on glycocalyx. It's a vascular endothelial membrane-bound layer, as we mentioned. It's made up of things like glycoproteins, glycosaminoglycans, and proteoglycans. And what it does is it's kind of like a really tight sieve. It helps maintain vascular integrity, reduces shearing force damage to blood on the vascular endothelium, so it protects the vascular endothelial cells, and by that function, it becomes antithrombotic, so it reduces platelet and clotting factor adhesion when if the cell membranes, if the vascular endothelium is intact Okay, so it's antithrombotic, so it's beneficial for patients with intact endothelium. And it also reduces adhesion and subsequent migration of inflammatory cells to the endothelium and migration into the interstitial spaces. Glycocalyx injury, what damages it and makes things bad? Glycocalyx injury results in capillary leakage. We get more tissue edema, so we get more fluid leaking out of blood vessels into the interstitial spaces because intact glycocalyx is antithrombotic. When that glycocalyx is damaged, we get hypercoagulability, so more platelets getting activated, greater activation of prothrombin. We get greater tissue inflammation. We get increased platelet aggregation and decreased vascular tone. The sorts of things that lead to damage of the glycocalyx are things like tumor necrosis factor alpha and oxidized lipoproteins. These are the sorts of things we're going to find with tissue trauma. Note that hypervolemia is a potential cause of glycocalyx damage. So that if we increase blood volume too quickly, or we have sustained hypertension in our patient's blood vessels, they can get damaged glycocalyx. Trauma can damage glycocalyx, so can surgery, so can growth factors, hydroxyethyl starch. We are unsure still as to whether or not that directly causes damage to the glycocalyx, but it's a theory out there. Thrombin and ischemia, reperfusion injury, those kinds of things are all associated with damage to the glycocalyx. Let's have a look at what it looks like. This is essentially what it looks like. Here's our vascular endothelial cells. We can see these nucleus here of a vascular endothelial cell, and the cell is just wrapping around the side of this capillary bed. And this area between these arrows here, between here and here, is the glycocalyx. Here it is blown up. Here it's like a little hairy layer on the inside of the lumen of our capillary beds. And this is a beneficial thing. When it gets damaged, we're more likely to get fluid and cells leaking out of the blood vessels into the interstitium. We're more likely to get clotting system activation and vasodilatation. So now some of you, and I know that some of you are the same age as me, most of you are probably younger, a few might be a little bit older, but when I went through vet school, I was taught that down the arteriolar end of a capillary, so as blood came in here, the hydrostatic pressure was so high that it forced fluid out of the blood vessels. But that at the venular end of a capillary, that because we had things like albumin, for example, and in later years albumin, maybe even hydroxyethyl starch or colloids, if we had big molecules sitting inside our venular end of the capillary, that there would be a reverse osmosis of fluid that would pull fluid into the intravascular space. Okay, and this was the premise behind using hydroxyethyl starch to improve tissue perfusion in patients with critical illness, and that is, we thought if we could fill up our blood vessels with big molecules, that fluid would be drawn back into the blood vessels, we get less edema, and things would be better for our patients. Well, there's everything you know is wrong with regards to that, and everything I've said to you just now is wrong, because what we now know is that there is no net movement of fluid back into the blood vessels at the venular end. There is just a net loss of fluid along the entire length of the capillary bed, including at the venular end. So we end up with a consistent loss of fluid into the interstitial spaces over the entire length of the capillary bed. So there is no reabsorption of fluid. So if I am to just change my drawing tool here, I'm going to draw a big cross through this because this is wrong, this is right. Okay, this is now what we know happens. This means that if I put big molecules like hydroxyethyl starch into my blood vessels, does that lead to a decrease in the net movement of fluid out into the interstitial spaces? Probably not, because I don't get any movement back into the blood vessel at the end of the capillary bed. So what do we do with colloids now that we've just looked at all of that? And I do love your comment, Claire. Oh, okay. Isn't science great? I mean, if science knew everything, it'd just stop, wouldn't it? But it doesn't know everything, so we keep learning new things. So, and I think that's absolutely brilliant that we're still learning after we've thought we'd known all this stuff, and now we find out that we were we were wrong earlier on. Anyway, let's break it down and come up with some practical recommendations. Take-home messages: treat shock aggressively with intravenous boluses. We're going to use crystalloids in the vast majority of patients. We're going to treat nice and early with our patient that's in shock. So give them their 10 mils per kilo of lactated ringer solution over 10 minutes, repeat it 2 or 3 times, and then back off on your intravenous fluid rates back down to maintenance rates until you can assess whether or not your patient needs more fluids. Sure, if they're dehydrated, we're going to need to rehydrate that patient, so there'll be a greater than maintenance rates of fluids while we're rehydrating them. But we do need to get back to that fluid requirement equals maintenance plus hydration deficits plus ongoing losses. And so maintenance is where we start from. We just add in hydration deficits. Once they're corrected, we go back to maintenance. And ongoing losses, how do I treat ongoing losses? I treat them with periodic boluses of intravenous fluid given as shock rates of IV fluid when my patient requires it, if they are losing significant volumes of fluid. Message number 2, avoid using 0.9% sodium chloride for resuscitation in any patient. You know, I guess there are a couple of diseases we get worried about using lactated ringer solution or other solutions containing potassium in them, for example. And one is where you have urethral obstruction and hyperkalemia, and the other one is maybe if you've got an Addisonian patient, and we reach for sometimes 0.9% sodium chloride in those patients. However, you could reasonably safely, in majority of patients, use lactated ringer solution or plasmolite, whatever other balanced isotonic polyionic crystalloid crystalloid fluid that you have in your practice, because 0.9% sodium chloride is an acidifying solution. So despite the fact that it doesn't have potassium in it, it will cause metabolic acidosis in your patient, a hyperchloremic metabolic acidosis in your patient. And that is going to lead to hydrogen ions moving from the extracellular space into the intracellular space in exchange for, drum roll please, potassium. So potassium gets kicked out of the cell and is now in the interstitial spaces where it can contribute to the hyperkalemia that you're concerned about in your patient. So volume expansion in a patient that has a urethral obstruction, for example, can be achieved reasonably safely using a balanced polyionic solution like lactated ringer solution. I'm not saying don't use 0.9% sodium chloride, perhaps in those patients. If you're really worried if the patient's got a potassium of 9 or something, then and you want to use 0.9% sodium chloride, then you know, for a few boluses until that patient then gets urine output re-established, I think is perfectly reasonable. So I'm not saying don't use 0.9% sodium chloride. I'm just saying that the benefit to using it over something like lactated ringer solution can be fairly small. Message number 3, if your patient is septic, avoid hydroxyethyl starch. A septic patient is one with systemic inflammation that is now beginning to become poorly responsive to intravenous fluids. In acute disease, hydroxyethyl starch doesn't appear to offer much advantage over isotonic balanced crystalloids. We used to think that it did. In fact, back in 2015, we were saying, hey, we could potentially still use hydroxyethyl starch, but it doesn't appear that it's of much value in patients. Ooh, just going to undo that. Doesn't appear that it's of much value to patients in surgery, anesthesia, to trauma patients, or in patients with medical diseases either. So maybe we don't need to use hydroxyethyl starch at all. Message number 5, if you are going to use it, okay, because you're concerned, maybe you've done an intestinal resection and anastomosis on a patient and you've given it hydroxyethyl starch, part of its preoperative fluid plan because of the improved anastomotic wound healing that occurs. Keep the doses low, okay? So the doses, daily doses, and I'd really only be using this on day 1 if I was going to use them at all, would be 6 mils per kilo in a cat and 10 to 12 mils per kilo in a dog. Give it in boluses of about 3 mils per kilo. This means you're going to give cats 2 boluses maximum over 10 minutes, and then you're going to stop for the rest of that animal's hospital stay. If you're going to use hydroxyethyl starch in dogs, you might get away with 3 or 4 boluses, 3 mils per kilo in 10 minutes. No continuous infusions. So that's message number 5. If your patient's septic, you need to trial an intravenous fluid bolus with a crystalloid. If you don't get any response after 10 to 20 minutes, then you need to start adding in vasopressors and inotropes. What is no response? No response is no improvement in heart rate, no improvement in pulse quality, blood pressure, blood lactate concentration, or urine output. If you're not seeing any change in those parameters that you're measuring, then you need to reach for vasopressors and inotropes. Plus or minus, if they don't work, then you might choose to use low doses of corticosteroids. Message number 7, blood lactate. In acute illness like a gastric dilatation, volvular syndrome, you should be able to normalize your blood lactate concentration within a couple of hours. And those patients in which you do that will have generally a slightly better outcome than in those patients in which your blood lactate concentration is still significantly elevated. And sepsis, we're aiming for about a 20% decrease in 4 hours. That will put your patient in a if you manage to decrease blood lactate concentration by greater than 20% within the first 4 hours, your patient is more likely to survive than if your blood lactate concentration has decreased less than 20% in the first 4 hours of fluid therapy. But just bear in mind, if I've got a patient with pancreatitis that's been sick for 2 or 3 days, I'm going to be aiming for a greater than 20% decrease in blood lactate concentration. If I have a hit by car patient, a dog attack victim, be it a dog or a cat, or a patient with GDV, I want my blood lactate concentration to be decreasing by greater than 80% within the first couple of hours of treatment, and preferably getting it down to normal. Message number 8, gelatins are not safer than hydroxyethyl starch. Just don't use them. So in the severely septic patient, these patients have got damaged glycocalyx. Colloids don't do what we thought they did. Crystalloids are safest. Avoid 0.9% sodium chloride. Treat shock in these septic patients, but you'll probably need vasopressors and inotropes to get better perfusion. I've seen there's been a number of questions come up there, so hopefully those conclusions have helped a little bit, but I'm just going to go back up and have a look at some of the questions. Claire said, at my clinic, we use lactated ringer solution pretty much for everything. We've got sodium chloride around, but almost never use it even for those FLUTD cats, which was a thing for some vets at one time because of the potassium and the lactated ringer solution. You're right, and I think we covered that, with just there not really being too much advantage to using 0.9% sodium chloride, even in those FLUTD cats. When in doubt, and get the Hartmans out. I like that. Oh, now, Siobhan, thank you for raising this. When are we using 0.9% sodium chloride? Yes, we still use it when we're doing transfusions. Sorry. If you are going to administer a transfusion, then I generally use 0.9% sodium chloride. There are some clinicians who are happy to administer it in lactated ringer solution or another polyionic solution. The problem is that the calcium, in theory, in lactated ringer solution may lead to inline activation of coagulation. It's been found not to be a major thing, but I must admit, being a creature of habit, I prefer to have just 0.9% sodium chloride. That's usually what most manufacturers of tick anti-serum, snake anti-venom, fresh frozen plasma are recommending if you're going to use it, or you can use a separate catheter. When we use hydroxyethyl starch, can you give other fluids at the same time? Yes, you can. So typically, if we just go back to what I was talking about before, when am I going to use them? I'm typically going to use them, if at all, during a period of acute shock resuscitation. So if you are going to use hydroxyethyl starch, what I would do is give my patient 10 mils per kilo, if it's a dog, 10 mils per kilo of lactated ringer solution in the first 10 minutes. And I stop my lactated ringer solution, and then I give them a 3 mil per kilo bolus of hydroxyethyl starch in the same IV line. And then I'll give them another bolus of 10 mils per kilo of lactated ringer solution after that. But that's how I generally do that. Are there any practical differences between Ringer's acetate and Ringer's lactate? Good question. There are subtle differences. Obviously, Ringer's acetate uses acetate as a buffer. Ringer's lactate uses lactate as the buffer. Ringer's acetate is, in theory, slightly safer to use in patients that have acute liver injury, so patients with acute liver necrosis, for example, or in patients with chronic liver disease, because it doesn't require metabolism in order to provide buffering of that IV fluid, whereas lactated Ringer solution, the lactate obviously is metabolized to acetate, so it requires hepatic metabolism. Renee has said, if your patient has a cardiac patient and we're concerned about volume overload, say you're doing an anesthetic and the blood pressure is low, would colloids be good in that case to reestablish better pressure and avoid the positive inotropic drugs? I love that question. That is really, really, really good question. So the problem is that if your glycocalyx is intact and you give your patient synthetic colloids, they will increase blood volume. Okay, and they'll increase it for longer than a bolus of isotonic crystalloids like lactated Ringer solution. So if I've got a patient in heart failure and I'm needing to give it some fluids in theatre, one of my biggest concerns is if I give my patient too much fluid, that my patient's heart failure will begin to decompensate, or my patient rather will begin to decompensate. Which do we think would be better? If I gave a fluid like lactated Ringer solution, where I expect 3/4 of it to leak out of the blood vessels into the interstitium in 30 to 60 minutes, so my blood volume will be smaller, there's less stress on my heart, albeit, yes, I'll have more fluid in my interstitial spaces, but I can give diuretics to help with that. Or would I give my patients synthetic colloids, which are going to increase my patient's blood pressure for longer and increase my patient's blood volume for longer, and subsequently increase pressure on my patient's heart? And I think if we think of it in that way, the solution becomes a little clearer. And I'd probably prefer to give my patient a smaller bolus of an isotonic crystalloid like lactated Ringer solution that's not going to last as long, just in case my patient deteriorates when it's had its IV fluids. Because the last thing I want to do is give my patient a bolus of 3 mils per kilo of hydroxyethyl starch, only to have that patient then decompensate due to heart failure, and for me to have that hydroxyethyl starch now stuck in those blood vessels for quite some time. So hopefully that makes sense, but that would be the approach that I would be using. Interesting question from Claire. There's message one, which is just treat these patients, get them down to maintenance if you need to. Does this apply to surgery? When we do surgery, we have the patient on surgical rates, then keep them on twice maintenance in some cases for a few hours before turning them down to maintenance. Should we turn them down to maintenance right away after surgery then? That's a great question, and I don't have a really short answer for you. I'm sorry, and I know I've gone over time, but here's the deal. So yes, you might have your patient on surgical rates, which we know now are lower than what they used to be. So for dogs, it might just be 5 or 6 mils per kilo per hour. For cats, maybe 3 or 4 mils per kilo per hour that we're having them on in surgery. Bear in mind that that is higher than maintenance rates during surgery, and so we will be accumulating some interstitial fluid. It depends what sort of anesthetic your patient has had and how well you've been able to manage it due to everything that's going on in your anesthetic. So if you have a patient who develops severe hypotension and you had to maintain that, you had difficulty getting that patient's blood pressure up over a period of time, and you were concerned that perhaps mean arterial pressure was hovering around that 60 millimeters of mercury mark that we know is at the level at which blood flow to the kidney starts to become compromised if it drops below that. So if we're worried about a period in the anesthetic in which our patient might have been hypotensive, then possibly what I would do is, yes, turn the fluid rate down to maintenance, but keep a really close watch on your patient. If they have a prolonged anesthetic recovery, then give them a bolus of IV fluids. If they're not recovering as quickly as you would expect them to, then give them a bolus of intravenous fluids, because oftentimes that provides enough to re-establish some better renal perfusion, and that can help with excretion of drugs, particularly if you've used drugs like diazepam. A lot of metabolites of anesthetic drugs are excreted in the kidneys, and we might get improved blood flow through the liver as well, and that might improve the rate at which these drugs are able to be metabolized and subsequently excreted. So in theory, yes, we can turn our fluid rates down to maintenance rates post-operatively, but I would temper that with the need to really monitor your patients closely, and if your blood pressure or anything like that is not as you would like it in the post-operative period, or the recovery seems prolonged, if you've got a patient with a urinary catheter in and it's not producing any urine, that's when I would use a bolus of IV fluids. Can I give some advice to treat hypoglycemia in a septic patient? We use 5% glucose solution, but sometimes it doesn't help. I don't want to increase the rate because 5% is hypotonic. Absolutely. So what I would do, Sophie, and thank you for your question, what I would do is, what I generally do is use, I'm going to type this in, 1 ml per kilo of 50% glucose. I'm going to dilute that in... So what I'm going to do is I'm going to give my patient 1 ml per kilo of 50% glucose, but before I give it to the patient, I'm going to dilute it in either saline or lactated ringer solution with 5 times the volume that I've just drawn up. Okay, so if I've driven up 5 mils, I'm going to give 25 mils of sodium chloride or 25 mils of lactated ringer solution, just so that the glucose concentration gets below 10%. And the reason I want to do that is that if I inject 50% glucose into my patient's blood vessels, that will cause a rapid osmotic shift from the vascular endothelial cells into the intravascular space, and that will cause a phlebitis. Okay, so with that solution made up, now I've got my 25 mils worth of, or 30 mils worth of solution. I'm going to inject that over about 3 to 5 minutes, so it's reasonably rapid. And then what I'm also going to do for my patient, that will raise the blood glucose concentration. Then I can start putting them on their 5% glucose concentration at 1 to 2 mils per kilo or thereabouts, as a means to try to help manage hypoglycemia. Hopefully that helps. How effective are shock crystalloid doses, in my opinion? That's a great question. So to treat shock in a patient that's hit by a car, has got a GDV, something like that, it's hypovolemic, they can be very, very effective. Usually you might need, between 1 and maybe 4 boluses. So you'd be treating the patient with shock rates of fluids for 10 to 30 or 40 minutes or so. In a lot of cases, those patients will stabilize. There are a fair number of patients, however, that have conditions that we can't necessarily see when this patient presents to us. It might have a pneumothorax, might be bleeding internally, may have fractures, for example. The patient may be in a lot of pain. There may be significant acid-base disturbances. There may be, in the case of GDV, just insufficient, there may be massive pooling of blood caudal to perhaps the caudal vena cava or the portal vein that prevents sufficient fluid from getting back to the heart and venous return. And so if you're seeing that your patient is not responding after 20 to 30 minutes or so, I would go looking for another cause. And your cause is going to be in the respiratory tract. It's going to be because the patient's bleeding, maybe because it's neurological, maybe there's an acid base or electrolyte disturbance, maybe there's cardiac disease, or maybe the patient is septic. So you have to go looking through a big list of reasons why your patient is not responding. But I really like that question. Do I give septic hemorrhagic gastroenteritis gastroenteritis patient's plasma? Again, this is a great question. Thanks, Sophie, for that question. Again, that's a complex question. But if my patient is septic and it's got hemorrhagic gastroenteritis and it has a coagulopathy, then plasma is indicated. The latest guidelines for giving transfusions in dogs and cats are based on some evidence that suggests that routine use of plasma just because your protein concentration is low, or just because your patient has even just a prolonged clotting time, is not necessarily associated with improved survival. What we're finding now more in the human medicine field is that they're using plasma a little bit earlier, and they're finding that it is associated with slightly improved survival times. So the current veterinary recommendations are for a septic hemorrhagic gastroenteritis patient, if it had a prolonged clotting time, I would be inclined to give that patient fresh frozen plasma. But if it is non-septic, it's just a hemorrhagic gastroenteritis patient, then and its clotting time is normal, then I probably would not see the need to give it fresh frozen plasma. But it's a complex question, and I haven't covered everything in that answer there. Which fluid do we need to use in a dog or cat with liver disease? So that would be Ringer's acetate would be the safest one to use for a patient with liver disease. Could you use 0.9% sodium chloride? Yes, you could, but it's not as good as a balanced polyionic solution. So see if you could get hold of some Ringer's acetate to go with your Ringer's lactate. This lecture has been race approved, I understand, so you will get CE credits, and I think Charisma is has just put the quiz certificate there, so you'll be able to get that. Hey, thank you so much, everyone, for coming along tonight. I do apologize for going over time, but I do just have a couple more things I want to tell you about. And this was obviously a lecture that's been brought to you by this upcoming course, Fluid Therapy in Small Animal Practice. We are going to talk about fluid types. We'll talk in detail about shock, and some of your questions that I didn't have time to dive into in a whole lot of detail. We're going to really spend a lot of time talking about hypovolemic shock, hemorrhagic shock. We'll talk about septic shock and anaphylactic shock, all of those types of shock. We'll talk about developing a fluid therapy plan, right from diagnosing shock to the beginning of treatment with it, when we give plasma, when we give red cells, when we need to use fluids of different types as far as managing electrolyte, glucose disturbances, hydration deficits, ongoing losses, and so on. So we actually develop an entire fluid therapy plan template. Then we go on to talk about fluid therapy in various disease states, including parvo and GDV, respiratory disease, patients with head trauma, and so on. We talk about transfusion therapy, and we fill in a lot more information about blood lactate and how we can use that as a monitoring tool for our patient too. There's loads of practice protocols. There's interactive tutorials a bit like this one. Lots of downloadable resources and cheat sheets. It's assessed with quizzes each week, and it's race approved for 20 CPD points. So if you need race CPD credits, if you don't need race, it's 20 structured hours of continuing professional development if you don't need race. But wait, there's more. I've also got a couple of free infographics for you as well when you register for the course. So visit our website, veteducation.com.au, and go on to courses, then scroll down to vet nurse courses and vet technician courses, and all the details of the course are there. I really want to thank you so much for coming along this evening. Your questions and your input and your enthusiasm is outstanding, and it's a privilege to spend the evening with you. So thank you so much again. I wish you all a happy and safe remainder of your week, and I hope to see a few of you at least on the upcoming course in fluid therapy. But actually, if you do have any questions between now and when the course starts, if you want some clarification, just shoot me through an email. And Charisma, if you could type my email address in there, that'd be great. And I'll put the music back on. Thank you, everyone, and good night.